all. This is Dr. Mubin Sayed from Drbeen.com. I have a very, very exciting news or the things to share today for COVID-19. Couple of things. There have been lots of questions, I think for 4 months now, that ACE inhibitors and ARBs, angiotensin receptor blockers, people who have been taking them, are they at an increased risk or are they protected or not? So we're going to talk about that. And secondly, this has been a discussion for a very long time, that how will the immune system respond? How does the immune system respond to the COVID-19, number one? And number two, what happens in mild cases versus what happens in the severe or acute cases? And finally, we knew that from SARS-CoV-1 that the immunity continues for about 3 years, and we had been hearing some grim reports that the antibodies start declining. So what is the real deal over there? How long are we protected? So that is the discussion. Interestingly, one of the studies that we'll share today is from Sweden. So we talked about Sweden yesterday. So this is a study coming from Sweden as well. So let's talk about these. Let me give you the basic gist of the whole topic. And then it is totally up to you to stay here, or if you wanted to go do something else, I would go into the mechanics after this. So the studies that I have seen here, these studies are showing that number one, the immune system response to COVID-19 is of two types. One is, and we have done this, I would say 3 types: innate arm only, especially for example in children, or the memory cells that produce the antibodies, and that is the most prevalent kind of response that we look for and that we measure for and we do tests for, etc. And then T helper 1 response as well, which is cytotoxic. And there was a continuous curiosity, at least in me, to say that what would happen if the cytotoxic T cell responded more than the B cells? And we have the response to that. So one of the studies said that it is actually mild and asymptomatic patients actually have cytotoxic response more than the humoral response. That is how they are protected, and they would stay protected as well. So that also means, remember yesterday we talked about the herd immunity, that herd immunity is not necessarily just, so this used to be my conjecture for a very long time, and I have talked about this in other videos, that herd immunity is not necessarily the people who have the antibodies. We have to look at the people who have better innate arm, and that can handle the virus, and the people whose T helper 1 pathway, the cytotoxic T cell pathway, may also be working, and we need to figure out how to measure them as well. Because if that is the case, just yesterday we talked about it, that it is possible that the herd immunity may be more than 11% or 20% in various areas. So that is one study. So the study says that T helper cytotoxic response works, and it becomes memory response, and it actually continues to help further. And when the cytotoxic response is present, then the symptoms are mild and asymptomatic patients are present as well. So that may be the right response on the immune system. The second study shows that the memory cells, the T cells and the B cells, continue to actually increase for some time. And even when the antibodies may have been going down, when the reinfection occurs, these memory cells jump into action and start working and protect the body. So reinfection actually will not be possible. This also means that the conjecture that I used to have, that if SARS-CoV-1 would trigger the immune response for 3 years, then why not SARS-CoV-2 have a similar response as well? And why are we talking about 3 months and so on? So these are the 2 studies. And the third study is that ACE inhibitors and ARB users, the patients who were already prescribed these drugs, these patients are actually at a reduced risk of catching COVID-19 or becoming sick with the COVID-19. So that is the basic studies. What I'm going to do is now I'm going to go through the studies and I'm going to show the mechanisms. So stick around if you would like, and we will go from there. So good day today, because this actually tells us if this happens, if the studies are correct, and that is actually broadly verified as well, then that would mean that the waiting for the vaccine was a correct approach. Then once the vaccines are there, or once more people get infected and recover, they would actually become immune for a long time. And so just like SARS-CoV-1, this virus is going to disappear as well, and hopefully very soon after the antibodies, after the vaccines as well. So good news here. So let's start. And of course, out of my excitement and didn't say it, welcome to everyone. And I'm very sorry for yesterday that I started the discussion and I somehow the screen sharing turned off and I just kept speaking without actually seeing that the screen was not being shared. I actually then deleted that video and redone the same topic when you guys had actually gone, but I came live again and did the topic again because I wanted to make sure that screen sharing was there. So my apologies for yesterday. Let's start. Yeah, good day today. So here is my dramatic cartoon for SARS-CoV-2, that we are, at least with these studies, we can now understand that we are on the right path in controlling this virus, and we are on the right path in understanding that the virus will actually would trigger similar immunity in us, virus or the vaccine, that would continue for years. And that is a very, very important thing to note. So the study is this. It is a study. This study is robust T-cell immunity in convalescent individuals with asymptomatic or mild COVID-19 cases. So please look at this title once more, mild and asymptomatic cases. I remember I had a discussion with a doctor from here. Her name is Dr. Gupta. She had called me and she was talking about why are some people having just mild or asymptomatic or have mild symptoms and others have such severe outcomes. And I used to think about that a lot as well. And I just had a conjecture. This is like 2 or 3 weeks ago. We were talking over the phone and I said, you know what, I think that there is something to do with the cytotoxic arm of the immune system as well. And it is possible that the asymptomatic or mild patients are actually getting managed by the cytotoxic arm instead of the humoral arm. And that is what is helping them. But I said, this is just my hypothesis. I have no data to back it up. So I'm very happy that today we have a study over here. So this study is coming from Stockholm, Sweden. So thanks to everyone over there. Very important study. And what they're saying is this. So I have highlighted some things over here. Let me show them here first. So look, we know this thing. So here are some of the known things. Number one, we know that rhesus macaque monkeys, when they are infected by the infection by the SARS-CoV-2, or like in Oxford study, when they were given the vaccine and then challenged again, they resist the infection and they did not become severely ill. So we know that there is a resistance to reinfection. Then as much as there are every month or so, there are news cycles that somebody became reinfected, but so far there has not been any evidence, real evidence, that people can become reinfected. Most of the time it is something to do with the person was released from the hospital with incorrectly and they still were having the virus, or they probably were long haulers, or they were carrying it for a longer period of time, but the reinfection itself has not proven yet. And that is a good news, because if it is not proven, that, and we have gotten so many cases now, the absence of reinfection actually also tells us that people can become immune and will stay immune for a longer period of time. Then this is something that we have been over here, the cool beans, we have been talking about some time now in last few days, that there are studies that showed that the antibodies are either less detectable or they start declining. So here is the answer. It is okay, because in such patients, it is possible that the T cell, cytotoxic T cell, were working more. So maybe they did not need the antibodies and they did not need the humoral system to respond, because a better wing of their immune system was responding, and that was the T helper cell, cytotoxic T cell response. So this is also a known that antibody in some people are not detectable, and they are with the patients of COVID-19 and they're still okay. Then we also know from previous studies that the mammary cells' responses are durable responses. Durable responses mean that they stay for longer period of time than 2 or 3 months. So the short of this discussion is going to be that we feel the studies shows that the immunity can actually live longer. And if immunity can live longer, then there would be a time that the virus would be eliminated. Why? Because imagine the whole world shuts down for a month. Everyone, nobody gets out. Virus, wherever it is present in people, would actually die there. I know that this is not practically possible to shut down the whole world, but if it was done, virus would go away. Similarly, if majority of the people had contracted the immunity either through the T cells or the B cells, then the virus would find it difficult to go to other people. That is the concept of the herd immunity. We've been talking about it. So we are on the right track. Now, this study said that one unknown was that the relation of the T cell response associated with antibody response to clinical features. What they are saying here is that there is a gap in our understanding. And I totally agree. I had been thinking about it as well, that for the various clinical features, mild cases, asymptomatic case, mild case, severe case, critical case, what is going on in the immune system? So these authors, thanks to them from, these authors are from Sweden, these researchers said that we wanted to answer this question. So that is the question answered. So I love it. It is what they did. They took 203 people. Many of them had traveled outside and came back to Sweden, or they had been in contact with a COVID-19 patient and they've been taking care of them. So they were patients, or they were people who were suspected cases or confirmed cases, and they were used in this study. They were taken in this study to participate. And what they had done was they took their plasma, they took their blood, and did the studies on their cell types. And what they looked at the maps of the CD4 cells and CD8 cells. CD4 cells are called helper cells. And in this map over here, we know that this is a helper cell, this is a helper cell, and then this is a cytotoxic T cell, and this is a B cell. This guy is also a helper cell, but this is a naive helper cell. So we just call it naive cell. So they're talking about these cells here. Then they're going to talk about this cell over here, and they're going to talk about this cell. I love the study over here, so I think I'm a little more excited than normal. So what they did was they mapped the CD4 cells and CD8 cells. CD8 cells are the cytotoxic cells. I remember it by, CD8. So 8 is like eating something. So the cytotoxic cell, CD8 cell, ate the other cells. So that is how we know that they are cytotoxic. They cause damage to the cells. And the B cells are humoral cells, or the antibody making cells. So back here, CD4 and CD8 cells is what they mapped. What they saw was, and here is the interesting bits now, CD4 and CD8 are less in acute or severe cases. Those patients who develop acute reaction or who develop critical reaction, who end up in hospitals and on ventilators, in them, B cells respond better than the T cells, cytotoxic T cells. So they have a humoral response. Humoral response is the antibody response. Why do we call it humoral response? In the early days, when we did not know that there are antibodies, when we would give plasma from one person to another person, that plasma would sometimes heal the other person. And so the researchers at that time used to say that there is something in this fluid that we give from one person to another which heals them. So they would say that some immunity is in this humor. Humor means this fluid. So the antibody, because antibodies run around in the blood and in the interstitial tissue fluids, we call that humoral response, and the cytotoxic response is cytotoxic response. So they found out that the cytotoxic responses were less in the patients who had become severely ill. On the other hand, patients who stayed asymptomatic or mildly symptomatic, they compared the CD4 and CD8 maps of these patients to severe patients, and they found out that the CD8 side and mammary T cell side was more robust in them. That is the basic thing that they found out. So let's go here for a second. What they did was, this is a busy chart, but I think that we all know this from our previous discussions. So look, here is where the things start. This is the innate arm, a macrophage or a dendritic cell. This cell comes in contact with the virus, that then this cell would present the virus antigen to a naive T cell. A naive T cell would then, in the presence of interleukin 4, will become a T helper 2 cell, which will then cause a B cell to become activated. An activated B cell is called a plasma cell, and the plasma cell would start making antibodies. This is the humoral response. This is the normal path that we are used to for SARS-CoV-2. But this response seems to be the better response. People who respond this way seem to have no symptoms or mild symptoms. So what happens is, in the presence of interleukin 12 is normally secreted by the macrophages and dendritic cells of the innate arm. When they secrete interleukin 12, that causes the naive T cell to become T helper 1 cell. T helper 1 cell in turn releases interleukin 2, and that causes a cytotoxic T cell to become activated. And the cytotoxic T cell that has become activated is over here. Look at this pairing of the cell, this adhesion of the cells. Here we have a cytotoxic T cell that is connected with a sick epithelial cell. Let's say this is the lungs epithelial cell, airway cell. This cell is sick with the virus, and it is presenting the virus antigen on its MHC1. A cytotoxic T cell is connected with it, and when the interleukin 2 is released and secreted, this cytotoxic T cell becomes active. And we have done this discussion in the past, that once a cytotoxic T cell becomes active, what happens is, what does it do? Can somebody tell me? So this is a cytotoxic T cell. Cytotoxic T cells are also called CD8 positive cells as well. They have a cluster of designation, which is called CD8. So what they do is, for another cell, so this is a normal cell, what they do is they release perforins. Remember perforins? They cause, yes, absolutely, Siddhartha, very good. Perforins and granzymes. So they release perforin proteins. These proteins would go and create perforations or holes in the target cell, the surrounding cell. And once that hole is created in the surrounding cells, number one, the fluids from the surrounding cell or the affected cell would start coming out, and the cell is starting to die. Secondly, through those holes, the granzymes is another protein that is released. I call them hand grenades. So granzymes are thrown or sent into this cell. And we have done this discussion many times before, that granzymes, their function is that when they go in a cell, they activate caspases. Caspases, you know, those Casper the friendly ghost thingy, that protein. So this is the Casper the friendly ghost. So they go in and they activate caspases. Caspases in turn tell the cell to die. So this is how the cell would commit suicide, and it would die with the viruses in it. And that is how further replication of the virus will be stalled, and spread of the virus would be stalled, or number of virus would be reduced. This is a function of a cytotoxic T cell. And they have found that in patients who are asymptomatic or mildly symptomatic, this wing is more active in them. That is one. Secondly, they found that the memory T cells are, these are T cells, all of them. This is a T cell. This is a T cell. Memory T cells are formed and are available, and whenever the infection reoccurs, then the memory T cell become activated, and they activate the remaining immune system. So maybe there is a patient who had become convalescent, who had recovered. He does have the memory cells, let's say T cells, and they do not have sufficient humoral response, because maybe they were responding through the cytotoxic system. Now when the reinfection occurs, the memory T cell would become activated once more. And what would they do? They would activate the other parts of the immune system, maybe cytotoxic T cell or the B cells, and the response would occur. That means if we are not looking at a higher number of antibodies, it is okay because they have the memory cells. When the infection would occur, the memory cells will become active, and they would trigger the system to start producing antibodies or the cytotoxic T cells. So that means when we are testing a person for past infection, just testing for the antibodies may not be necessary or may not be enough. Remember, I was talking about this yesterday for herd immunity, that for herd immunity, we have to see people whose natural killer cells have been more active and they do not need the rest of the system to become active, then people whose cytotoxic T cells were active, then people whose B cells were active. We have to combine them all to understand how many people have become immune. And that is what is happening here. Mammary cells are available. Now what happens is, this is a normal behavior of our immune system, that when we have a mammary cell, so let's say this is a mammary cell. When a mammary cell is sitting somewhere, it is sleeping, if it is a B cell, it would keep its receptor out. So I visualize this as a cell sleeping on a shelf and keeping his hand out. And if it grabs the right thing, so let's say this is my water bottle and this is the antigen, and the cell is sleeping with the hand out. And if it grabs that antigen, for example, the virus arrived in my body once more, as soon as it grabs it, it would wake up and it would start working. And what is the work? First of all, it would become proliferated. That means it would make copies of itself. So an army will be generated. Then all of them would start making antibodies. And similarly, if it is a cytotoxic T cell, then what would happen is it is sleeping again as well with its MHC1 or the cytotoxic T cell receptor, out. And as soon as the antigen would be there, the cytotoxic T cell would become activated. Or if it is a mammary helper T cell, which is this guy, as soon as it is sleeping as well, and as soon as the antigen comes in, it is going to get connected to it, and it is going to wake up, and it is going to do what? It is going to activate this arm or this arm, whichever arm it can activate, and the immune response would start. So then once again, if somebody doesn't have the antibodies, that does not necessarily mean that they did not have the infection in the past. And it doesn't necessarily mean that they may not be protected, because maybe their cytotoxic arm or the mammary helper cells are present. We do not have tests today to go and measure those or find those cells. So beautiful thing here. For the medicos in the discussion here, I just wanted to talk about this as well. In the study, what they did was they separated out the cells, the helper cells and T cells, by looking at the following markers. For the helper cells, CD38, CD39, Ki67, and PD1. These were the markers that identified the mammary T cells. And then on the cytotoxic cell side, they looked at the CD38, 39, 69, CTLA4, cytotoxic, what is that? Antigen 4 protein, Ki67, leukogen antigen protein as well, 3, LAG, HLA-DR, and TIM3. So they were looking at those to kind of separate out the kind of cells that they were looking at. So that is what they had done. One more thing that they saw, and again, this is not a new discovery. These are the things in immunology. I taught immunology 12 years ago, and we used to talk about that at that time as well. So it's not new, but still it is important that these cells, they said the mammary cells have stem cell-like behavior. And stem cell-like behavior means what? A stem cell is a cell which, when it divides, it can give rise to daughter cells that are different kind of cells, and it can give rise to its own kind as well. So it is like if we are parenting our children, if we are capable of making children who are exactly 100% the same as us, and then some children are different, then we will be called stem cells or stem parents. So stem cells are the one that can give rise to their own type plus newer types. So over here, they're saying that the mammary helper cells have stem cell-like behavior. That means they can regenerate more of helper cells, plus they can regenerate other type of cells. So that is the discussion. So look at this. Doesn't this change our view on herd immunity? Talked about it yesterday as well. I just talked about it now as well. Secondly, doesn't this change our view for the severity of the immune response, this one huge knowledge gap is filled now, that people who have milder symptoms, they have a different immune response, and now we know what immune response. And people who have severer symptoms, they have a different immune response, and now we know what immune response. I remember talking in one of our previous lectures. I was not aware of these studies. This is like 2 months ago. I remember talking in one of our lectures and I said that at some point we have to invent a test that can look at our immune system cells and see how are they going to respond, T helper 2 pathway or T helper 1 pathway. And based on that, we should be able to predict how would a person respond to the actual infection and then protect them accordingly. And here is a study that talks about it. I'm excited about it. Okay, so let's continue. So then the second study. So here is the first study. I'm just going to scroll over a few points over here, which were interesting. I've highlighted them. I would request you to go read this as well. I have the link out there. So this is the study. Had to go over this and look at it, but beautiful, beautiful study they've done. All right, so the second study is this one. This is the functional SARS-CoV-2 specific immune memory persists after mild COVID-19, and this is from the University of Washington School of Medicine, Seattle, Washington. So I think this is the most important part, and I'm going to go with that one. So here, in this study as well, it's a very similar study to the other one, or in the same vein. This study says the following. They say that the memory cells are developed after a mild infection, number one. So we just saw, yes, they do develop. Even in asymptomatic state, they can be developed. Secondly, they can become activated. And when they become activated, they start proliferating, they start dividing. We just talked about it. And then they start attacking the virus, or they start providing a response. We just talked about that as well. Very similar studies. The interesting thing that this study have found is the following. They said that the T cells, once they are activated, memory T cells, once they are activated, they start secreting interferon gamma. This is a very interesting clue. Why is it an interesting clue? Cool Beans, tell me. Why is interferon gamma an interesting clue over here? Because, and I'll tell you a tiny story. 4 months ago, I did a lecture. I still have that lecture on YouTube. YouTube didn't take it down. That lecture was that why does SARS-CoV kill so rapidly, or rapid death by SARS-CoV-2? In that discussion, I said that it is also possible that the helper cells would produce interferon gamma that would cause the innate arm to become activated, and that amplification can become harmful. So there was someone who was an immunologist. He became very, very upset with me, and he said, look, none of the studies till today, 4 months ago, he said, none of the studies have mentioned, in case of SARS-CoV-2, the presence of interferon gamma. Why are you mentioning it? And so I responded and I said, look, this is the immune system mechanism. We know immune system and how it works from now decades. So it is not I'm not hypothesizing a new science here. I'm just talking about the existing science. And I'm saying that if this pathway is activated, this pathway will produce interferon gamma, and that interferon gamma would cause the innate arm to become amplified. And this is a known thing. And he said, you cannot talk about any known thing as well, which is not yet proved for SARS-CoV-2. And of course, I stopped further commenting with that person. But this is a similar thing, like WHO does not, it looks like for them, everything is new about SARS-CoV-2, although I showed that books have the content in there which talk about how to manage and what to expect. It is the same thing here. So 4 months later, there is a study that is actually showing it. So here is what it is showing. They are saying that when the memory cells become activated, they start producing interferon gamma. Do you know what is interesting in here? This means cytotoxic wing was active. Interferon gamma is produced from the cytotoxic side, from this wing of the immune system. Interferon gamma is not produced in this wing or the humoral wing. And 4 months ago, we did not know this. So that doctor was correct, who was an immunologist. He said, I'm an immunologist. How dare you talk about it without, he thought I did not know. Anyways, he was correct in this way that we did not know at that time that SARS-CoV-2 can cause T helper 1 pathway or not. But now we know that it can cause, and if this pathway is active, then this pathway is going to produce interferon gamma. Interferon gamma would then in turn activate the innate arm. This is called IL-12 interferon gamma axis. Innate arm produces IL-12 to activate the adaptive arm, and then the adaptive arm T helper 1 pathway produces interferon gamma to activate the innate arm. So that is an amplification pathway, and we call it interferon gamma, IL-12 interferon gamma axis. This study found that when mammary T cells are reactivated because of the infection again, they start producing interferon gamma. That means this pathway becomes active as well. So I'm kind of excited about this as well. So this is the discussion for these two studies. I'm sorry if I'm more excited and I've repeated that. I've talked about it before as well, but hopefully that is okay and you can forgive me for talking about it. All right, so then finally, so what is the takeaway from these two studies? The takeaway from these two studies is that just like SARS-CoV-1, we should expect immunity with SARS-CoV-2 as well, which is durable and prolonged. And if we become immune for a longer period of time, the virus will not have more people to go to. That is sort of the herd immunity, and the virus would disappear. So that is a good news. I now want to talk about one last topic for today, and this is a topic that we have been talking about for some time too, and I did not have a decent study to hang my hat on and say that I think I have an answer for this one. And the question was, what is the risk of severe COVID-19 disease with ACE inhibitors and angiotensin receptor blockers? So if people who are taking ACE inhibitors or angiotensin receptor blockers, are they at a risk or not? So the study, I would just read out the conclusion over here. ACE inhibitors, if you read here, ACE inhibitors and ARBs are associated with reduced risk of COVID-19 disease after adjusting for a wide range of variables. And what they had done was, in this study, they had taken, I think, 1,205 patients who were already taking ACE inhibitors or ARBs, and then they did a prospective study on them. That is that they identified those patients, and then they kept following them to see if they developed the disease or not, and if they did develop the disease, if they became serious with that or not, if they went to ICU with that or not. So their conclusion is that, I would just read it once more over here, ACE inhibitors and ARBs are associated with reduced risk of COVID-19 disease after adjusting for a wide range of the variables. Neither ACE inhibitors nor ARBs are associated with significantly increased risk of receiving ICU care. So they do not increase the risk of a person to end up in ICU. And down further in the study, they also say they also do not reduce the risk. So they do not have any effect on the ICU admissions, but they do have the effect in reducing the disease itself. So that is a discussion for today. Hope I was sharing my screen, and hope you guys are all doing good. The cool beans are doing good. It is a good day. It's a nice study out here. Tell me, let's just take a couple of questions and then we stop. So tell me this, do you like, subscribe, and share? Do you feel that this content is actually helping and serving? Sometimes I feel that I just, it's about 4 months. I hope I'm not wasting your time. So I hope that you are taking benefit from this. Please do me one favor. Please like, subscribe, and share as well. And we'll go from there. All right. So, and please put your questions for this Friday's open forum as well. We'll have that discussion. Tomorrow we will continue. And I wanted to make a comment about a study. Somebody had tagged me on Twitter. That study was actually, it's not a study, it was a hypothesis that the person had hypothesized that the virus enters our immune privileged sites, and that is where it hides and causes long haul symptoms. So I have read that article. I am not yet convinced. The person who wrote this is not a doctor or a researcher. I'm not yet convinced for the hypothesis yet. There are more immune privileged sites in our body than what they have talked about in that paper. So I have to actually research more before I can say that hypothesis is correct or not. So just one comment for this one for our Twitter audience. So thank you very much. Have a good day. Stay happy and healthy. Please stay protected for a couple of more months. We will have vaccines, and then we would have this immunity that would develop. And I hope that if you do not have a vaccine and you develop the infection, I hope it stays in the milder stage. I hope your supplements and you're doing all those things so that you then develop immunity and be done with it for 2-3 years. And by that time, this virus would have gone. So please stay protected, stay indoors, wear your masks, and stay healthy. Talk to you tomorrow.